You recognize the Noonan Youth Council. Would y'all like to stand up? You're over here to the left. Like that. Thank you. Here to learn about good government. You certainly have a good person with Representative Lynn Smith, who's not on this committee, to represent you down in Noonan. Okay, I would like to call House Bill 36, and I understand that Chairman Meadows would like to go first. So Chairman Meadows. Pardon?
I'd like for Earl to do the opening.
Okay, that's fine, sir. Okay. Representative Earhart, if you would present the bill.
Thank you, Madam Chairman, and I'll be respectful of the committee's time. I know that Chairman Meadows has somewhere to be also. Madam Chairman, members of the committee, I bring to you House Bill 36. This is a scope measure, so as always, these are somewhat, let's just say there's some angst generally in a scope discussion. We've done this for many, many years. I think this is probably over 20 years that I've been involved in optometric and ophthalmology scope issues, so I've spent a significant amount of time studying this issue. I've been to the optometric schools. I've talked to the ophthalmologists in my district, those that agree and those that disagree, so, and the optometrists. So this is a very straightforward proposition. I don't like to use the word simple proposition with respect to that. What this does is establishes a process by which optometrists are able to be credentialed to perform certain injections into the eyelid and mucous membrane of the eye. I'm not going to get into the scientific differentials with respect to what the globe of the eye is, but it's the eyelid, not the eyeball, for the lack of a scientific term in that. There's a scientific term, but if you want to use that, I can go into it and we'll look up the definitions. Why are these injections necessary? There's currently are medications administered via injection to treat everything from papillomas to chalazions and epidermoid cyst, and additionally, the researchers are looking forward to introducing new technologies. This is always the case in medicine, involving the use of microneedles to treat glaucoma and other issues. Students of optometry are currently being trained and tested on ability to perform these injections, and have received this training for, this is important, the past 10 years. Why remove these classes of drugs? As technology advances, there'll be future medications that may not fit in the current classes allowed to optometrists, thereby preventing optometrists from providing patients with the best possible health care. Ladies and gentlemen, optometrists provide a significant amount of eye care in this state. There's very few, approximately 350 ophthalmologists. There's over 1,000 optometrists. If you're in a rural area of the state and you need this type of care, it's much easier sometimes to get to your optometrist rather than having to go to where many ophthalmologists are. The training is conducted not only in their schools, but didactically and through the clinical methods that optometrists are trained on. These are individuals who have 4 years of training. Sometimes the arguments with respect to this issue get so caught up in turf battles, and there's things that are said that are just necessarily not needing to be said in this arena. These are highly trained professionals that do this. They work very hard. They take the continuing education. This is not I would never have involved myself in any of these issues. I thought public health and safety were actually at risk with one of these, and it's been proven that it hasn't been. And I want to talk about that a little bit because there are 15 states that currently allow these procedures. Ladies and gentlemen, that's 15 states, including our neighbor Tennessee, where it's been done over 20 years. Now, I've made this case many times about this because every time we go into this, the world is coming to an end. In this medical arena, if somebody were to perform something that harmed a patient in any medical profession, there's generally a lawsuit brought. There has been no lawsuit brought in these states for 14 years, 15 states, over 20 years in Tennessee. Believe me, if there were a problem, there'd be people suing about this. This has been the case. This has been the boogeyman that I've had to deal with every single time. And just as anecdotally, none of the things we've changed in the last 10 years with respect to this have resulted in any torts. So just keep that in mind if you want to say that this is not a safe and sound program. Ladies and gentlemen, this is not a difficult issue. These professionals are trained. They take the same courses at UAB Birmingham with their physician counterparts. They learn from their instructors how to do this. They learn through all of the different methods they take after they graduate to do this. And they're in this bill, they're going to take continuing education and get a certification, just like you have to do in many professions in order to step up your game. So this is a proposition that's time has come. It's not a problem or a safety problem for the public. Again, go find somewhere in some other state that this has been a problem, and show me why it's not good for the people of Georgia to have access to this type of health care. Thank you, Madam Chairman.
Mr. Chairman.
Thank you, Madam Chair, members of the committee. I don't have a lot to add to what Earl's proposed, but I just want to tell you why I'm here. I have had opportunity to see how well an ophthalmologist and an optometrist have worked together to save the sight of a friend of mine. I have found out that across this state there are scores of ophthalmologists and optometrists that are in business together. They use the same building, the same floor, and use most of the same staff. In the last 7 years, and again, I apologize for not having 13 years of experience with ophthalmologists and optometrists, but I've had about 7, and over those 7 years I have noticed, whether you believe what some folks are sending you on your emails, a relationship that has grown extremely well. I won't say that my ophthalmologist and optometrist are hugged up on one another, but I will tell you that they're holding hands. Optometrists need the ability to do these shots. Number one reason, and Earl mentioned it, do you know that in parts of this state we don't have hospitals? Do you know that in parts of this state we don't have ophthalmologists? Do you know that in most of these small communities I do have an optometrist? And those optometrists do their best to serve their clients, and when they get to a point that they can't help, they send them to an ophthalmologist, even though it might be 132 miles away. They send them to an ophthalmologist. Optometrists, while not going to med school, they go to optometry school. Believe it or not, they take a series of courses, and they all end in ology, where they're taught this method of giving injections. A funny thing happens. Once you're taught and once you get out, you hit the state wall. You can't practice what you've been taught because of a state law. My ophthalmologist, on the other hand, go right on forward. Yes, they have more experience doing this, but it's because that's what they've been doing since they got there. Is that a drawback to an optometrist? And the answer is absolutely, because the one thing that's going to happen, every one of these people that want to do this procedure are going back to school. Just like you probably have to get continuing education in some form or fashion for whatever your chosen profession is, you got to get continuing education. And until they've had a review, because they had the education up to a point, they just couldn't practice it. They're going to have to go back and get certified that they are capable of doing this procedure. When we first started this, the intent was for there to be two names on the bill, and Earl and I have done it before. Is just have us. There's several that jumped on there and signed without our knowledge, and that I don't want to go out here and say have I been giving anybody in here the hard sell, and the cold hard facts I haven't. All I've asked is that you listen, and if we have a convincing enough story, I would like for you to vote it out. And then somewhere along the line, I can assure you it'll get on the floor. But can you imagine being a member of this body and me and Earl come to your desk and say, hey, we want you to sign this bill? How many would sign it? I'd be willing to bet you 90% would. But we didn't do that. And we've stayed in the background. There's no pressure been put on anybody that if you've been pressured, I want to know who by and why. If it's a lobbyist that's pressuring you, that's why they get paid. They're out pushing their product. But Earl and I, we think it's a good bill. We're asking that you give it your consideration, and remember that we want what we think might help the people of the state of Georgia, particularly those people in rural areas who do not have and cannot get the quality of care that we get in our more metropolitan areas and our larger cities. We appreciate your time and would ask that if you've got questions, you're going to have to ask them of Earl, because I got to go. But just give us your consideration. That's all we ask. Thank you, Madam Chair.
Well, thank you, Mr. Chairman. I was going to ask if anybody had questions of you, but since you're leaving, we'll direct them toward Representative Earl. Okay. Representative Pizzo.
Thank you, Madam Chair. Chairman Earhart, because I'm a hamburger salesman by trade and an Auburn graduate, reading comprehension is not necessarily my strongest suit. But over the weekend, had some bedtime reading, and I was going through this bill, and I had to open up my laptop and pull out Google. I'm going to direct you to line 39. Reads, an injection that is not subtenon retrobulbar. Now, I have no idea what that meant, so I Googled it, and it corrected me, retrobulbar, B-U-L-B-A-R. Should that be corrected in this legislation?
Representative,
And I had a 2.52 GPA at Auburn as well. So
I'm not gonna. My wife is an Auburn graduate, and I'm not going down that path. I'm going to demonstrate some of my better sense with that. I think Auburn graduates are wonderful, and they're probably some of the smartest people on the planet. How's that?
with some exceptions.
Okay, well, I'm going to let you take that on. With respect to the definition of retrobulbar, it may be retrobulbar. I think if that's a Scrivener's error, then I'm more than happy to
Okay.
accept.
Can we? I'll let the Madam Chair make that motion.
I have no opposition to it.
Thank
for the
you, Madam Chair.
correction. Does anybody on the committee have any objections to that correction? I hear no objections, so it's corrected.
Thank you.
Okay.
Don't put it in your hamburgers.
All right, Representative Mitchell.
I don't know if this is, are you entertaining motions at this time, Madam Chair?
Recognized for that motion at this time. Do we have any other questions? Okay. Representative Hatchett.
Thank you, Madam Chair. I've just got to follow up on this. What does that mean? Oh, you can't? Okay.
I don't believe Representative Pizzo, I don't believe he addressed the question to you. He addressed it to the author of the bill. You're not recognized at this time.
Representative Hatchett, I'm not clear. I know what subtenon is. I know what intraocular is. I know what a botulinus is, but I do not know the definition of retrobulbar. That is one that I can't get. I've actually voted on bills down here from the Pharmacists Association that I couldn't even begin to pronounce. So there is some history with respect to unpronounceable medical terms. I don't know that it's specifically a major issue. I'll defer to some of the physicians or optometrists that are in this room.
Okay, now Representative Peasold, since Representative Earhart was not. Now you can give was it Wikipedia's?
No, ma'am. It is Google.
Okay.
Retrobulbar is behind the eyeball. You're welcome.
That makes sense. Thank you very much.
Thank you, Madam Chair.
Okay. Do you know how one gets behind the eyeball?
Very carefully, Madam Chair.
So, okay. That would be a little bit beyond the eyelid, wouldn't it? To get behind the eyeball. Representative Price.
Related to line 39, does injection include anything other than those prohibited?
That's what it says.
So any place in the body?
This is not specific to any place in the body. This is specific to the eyes and to diseases of the eye. If it were to get into the entire macro of the physical body, that would be a different different specialty. Optometrists and ophthalmologists are not necessarily trained on specialties of the foot, like a podiatrist may be trained on and that kind of thing. This legislation is with respect to the eye. It's not going into
Right, but
the rest of the body.
could you imagine a situation where an intramuscular or an intravenous injection might be appropriate for treatment of an eye condition?
If it's within the protocols that are in the rest of the statute with respect to optometry, then it would be allowed. If it's not, it wouldn't be allowed. Just as a
And can you tell me
surgeon
why
that's practicing.
the line 33? No,
Representative Price.
oh, can I
think that
no more
Represent-
questions?
I thought, no, it's fine, but I thought Representative Earhart hadn't finished answering your question.
That's okay. We can move on to the second part. Line 49, you said, Representative Price?
No, actually, line 33, I'm wondering why we have removed the list of approved medications, which then makes it rather exhaustive, the number of medications that could be used.
I think I addressed that in my testimony, but I'll be more than happy to go back to it. Why remove the classes of drugs? Technology advances is the short answer. There's future medications that may not fit into the current classes allowed. That's why we have the medical boards, the boards of optometry and the boards of medicine. We need to be able to allow these doctors to provide the best possible care for their patients, and a more flexible, but still overseen by the board, which is a basic part of our statutory authority. Their statutory authority is a reasonable thing to do in my mind.
And are you aware of any connection between diseases of the eye and it maybe being a symptom of diseases throughout the body?
I'm not, but I've spoken with many ophthalmologists and optometrists practice together for just that reason. Representative, they consult. They have histories of looking at just those types of symptoms, and they're very well trained to not only diagnose those symptoms, but to reach out, whether they're an optometrist or ophthalmologist, for a specialist if there's something that they don't understand. That's part of their basic protocols.
Well, there's an old adage in medicine, which is you don't know what you don't know. So how would the optometrist know that he needs to confer with an ophthalmologist if he really doesn't know what he doesn't know?
If he doesn't know or she doesn't know, then they refer to someone who may know. That's the second part of that old axiom. I mean, just as a surgeon that specializes in orthopedics doesn't necessarily know that they have a tracheal problem, they would probably reach out based on their training to somebody who was specialized in diseases of the throat. I mean, the second half of that equation and the calculus is very simple. If you don't know, then you reach out. I mean, that's what a professional does. These are highly trained professionals with 4 years of medical training. I've been to their schools.
Now, the definition of optometry basically is related to visual issues. So I'm having a hard time figuring out why there's going to be a need for any injection if it's not impairing vision.
Representative, again, 15 states have done this.
We're in Georgia.
Yes, we are. And the experience in other areas has been that this is good for the citizens and good for the health care of those regions. That's what I'm relying on, and I think it's a good idea.
Now, Representative Earhart, I bet you when your boys, who turned out very well, I bet you when they said they wanted to do something just because everybody else was doing it, you didn't buy that.
No, but if they came to me with a great factual argument, I let them win sometimes.
You let them win sometimes. Okay. Representative Price's questions have made me wonder about something, and I guess I'd have to ask Betsy. Betsy, if it is silent on the injectables, then would it allow them to give any injectables that they wanted, IM or otherwise?
You have to read it in conjunction with, starting on line 54, and on line 58 specifically it says used for ocular pain, so you have to argue that an injection somewhere else in your body is for ocular pain, which I guess you could, but the training, I mean, the regular scope of practice though of an optometrist is limited to the eye, so reading all that together, I think it would.
That was what I said.
Be limited to the eye as long as it met those criteria.
I mean, Representative Earhart, would you have any objection to that being added just for clarification and comfort that it was only at the proper place?
With respect to I think what Betsy said was that the practice of optometry and their treatment is not the systemic entire person. It is the practice of the eye. It is not. Again, their protocols are already limited by the statute. I'd be more than willing to look at the statute as a whole and make sure that that was the case. But I think like you said, when you read it as a body of law, then there is no necessary room for clarification of what is already stated in the statute.
Okay, we'll move forward, but sometimes we do put things in just to clarify issues, even though they are, stated at other places.
Let me put it this way. If we had a restatement of what it says with respect to the practice of optometry in the existing statute into this, then I don't see that as a problem. It would be a redundancy in the statute, but if it helps to make it clear and if it's the same verbiage that's in the current statute that is with respect to the scope of the practice, then I wouldn't have any issue with it.
Okay. Betsy, you might look and see if there's a place to put that, or just think about it. Okay, thank you for
Thank you for
Representative Earhart. Okay, Representative Matriarch. Did I get it right?
Close enough.
Okay.
Thank you, Madam Chair. Let's go back to the education, because the ophthalmologists that have spoken to me are very concerned about the education, and I've even gotten calls from students. So can you walk me through that?
I can.
Sir? Thank you.
An optometrist, like most professionals in the medical fields, have 4 years of undergraduate education. Then they go through a 4-year doctoral program in the practice of optometry. And this is where I spent a significant amount of time. I have visited the UAB Birmingham. I've gone and sat through the classes where the optometry students sit side by side with the physician students while they're learning the same clinical pieces with respect to the eye. This is where they get that didactic training. That's where a professor imparts the knowledge. Then you have residency programs for physicians. You have clinical programs. It's a rigorous series, and it's understanding medications, the description of, and the administration of. It is well respected nationwide. This is not a simple trade school where you go to get a certificate that you can hang on the wall that says you've been through a weekend course. This is a very difficult program. We actually have, through 2 programs here in the state of Georgia that we administer through the higher ed budget, to provide scholarships to optometry students here in the state of Georgia because we don't have enough. Again, that's more of a rural healthcare problem. But what I want to get across to you is it is a very, and then to go one step further, to be allowed to do this, you still have to obtain the certification that's going to be necessary to get to that point.
Madam Chair,
Yes, one more.
Okay, and then for the docs that are already in practice, they will have to go back and be recertified for these injections, correct?
That's correct. That's what it says in the bill.
Thank you.
And they also have to take, the optometry programs are probably the most vigorous with respect to their internships and externships that are required in those years as well. So it is a long and rigorous process.
Representative Earhart, can you tell me what that certification entails, since it's not defined?
Let me read it here from the bill, Madam Chairman. It's a injectables training programs on line 47. Injectables training program sponsored by a school or college of optometry, credentialed by the United States Department of Education and the Council of Post-Secondary Accreditation in order to fulfill the requirements of such training program and under the direct supervision of a doctor of optometry who holds his current license or certification of registration issued by the board or under the direct supervision of a board certified physician in ophthalmology who is licensed to practice medicine in the state. That's the basic standard for this
And
certification.
do you have any idea how many hours that is? How many, the approval? Is it, a 4-hour course, a weekend course, or do you have?
I would assume it meets the basics, not just basic. I assume it meets the standards of the USD Department of Education, the Council of Post-Secondary Accreditation, just as any new technology a physician would have to go through, or anybody in a professional. Let's take it out of lawyers and
Well,
aristocratic
maybe
side,
somebody from the.
But I'm just saying that it's going to meet a standard that these agencies have determined to be sufficient to safely do this procedure for the public that they'd be practicing it on. I don't have the exact time frame. Maybe somebody else who's
Somebody
involved in
can
this.
maybe give me that, because I don't mean to be disrespectful.
That's all right. No, I'll take it that way.
But I have seen some of the continuing educations for nurses and other areas which are weekend, weekend
We can always do
courses
better
and-
on CE.
Pardon?
I would agree. We can always do better in CE.
Right, and continuing.
And your committee's done a good job with
Medical
looking at that
education,
over the
right.
years.
So that, okay, wait a minute, I saw it. Okay, Representative Beverly, who I think is our optometrist on the committee.
Thank you, Madam Chair. And I am an optometrist, just for the record. But I wanted to go back to line, there was a question about scope of practice that we asked, and if you, Representative Earhart, if you take a look at line 20 through, I think it's lines 25, I think that maybe that gets to the issue that you raised, Madam Chair, about adding another line. If you read those, line 20 through 25, that may address the issue with scope.
That is scope language, no doubt. That's existing code. There's also regulatory authority, which is a part of this as well, which I don't have in front of me.
Okay. Representative Drenner.
Thank you, Madam Chair.
Where is she?
Right here.
Oh, I'm sorry, I didn't see you.
That's okay. I'm trying to be,
Demetrius has taken up all the,
before, Chairman Earhart, I'm sure I mentioned this to you. My stepfather, was an optometrist and the chair of the Southern Optometric Association, and I have 2 stepsisters that are also optometrists. And my question is really fundamental to you, is so what is the difference between an optometrist and an ophthalmologist, curriculum-wise? What are we talking about in terms of the differences?
I think there are substantive differences in the professions. I don't see optometrists practicing surgeries of the eye. They don't anesthetize their patients and put them under for surgical procedures. There's training that ophthalmologists receive through their clinical residencies that is hospital based, and there's a difference in scope between the two. But again, what I'm proposing, I don't think is a massive expansion of scope. It may be different in Georgia, but it is, again, we've had these discussions. I remember when Georgia was the only state in the nation that did, other than on a military basis, I think you co-sponsored that bill with me, that didn't allow certain eye drops,
Yeah.
so to speak. And it seemed like an unreasonable restriction at the time. And I think this is, especially with a safety record that's already in place in even our neighboring state of Tennessee, that this isn't an overreach. It's a reasonable expectation for people who need access to this type of health care.
Thank you.
Okay. Representative Silcox.
Just as a point of clarification, Representative Earhart, Mr. Chairman, isn't it true that actually those in ophthalmology do receive more training? It's my understanding they receive 4 years of college undergraduate, 4 years of medical school, 4 years of ophthalmology residency, and then many of them also go on to do fellowship training. So they receive 4 to 5 years more of training. Isn't that correct?
I didn't mean in any way to disparage the amount of training that an ophthalmologist, because that's why I was saying that I think they perform surgeries, and those are the kinds of things that require that further on training. All I am advocating for and also pointing out is that the training that an optometrist receives is fairly significant compared to many other programs, and that, in my opinion, and those and many others, that this training is more than sufficient for this particular procedure and scope. So if there was in no way meant to minimize the training of that. But again, the distinction to me is those are further trainings to do a lot of other things that are not as specific to this. They receive training on eye drops too, but we can still let that.
Isn't it true that it's important for if someone's getting an injection in their eye, for someone to have general anesthesia so that they don't move and perhaps jeopardize the injection or jeopardize their sight?
I've heard that, but I've also seen that that's not an issue in the areas where it's done otherwise.
And then I noticed on line 39, going back to that favorite line of everybody's, my understanding is that there are 4 layers to the eye. And I noticed in that list that perhaps the conjunctiva, which is the first layer of the eye, is my understanding, is not mentioned there, so that injections could be done in the first layer of the eye, correct, since they're not mentioned?
I'll tell you what I'm going to do. I'm going to defer these questions. I know there are medical professionals that probably want to testify on both sides of this. I think Dr. Beverly could probably answer that better than I can. My presentation is more to the specifics of why I think it's safe, it's reasonable. If we have to get into the technical side of this equation, I'm going to defer to those who can answer the question specifically.
Thank you.
Okay. Representative Sharper.
Thank you, Madam Chair. I'm just looking at, the one portion of this, I'm looking at the scope of practice. I mean, I've been in medical field 28 years now, and I still have an open mind to making my decision today. But the thing that I'm looking at is if they don't have if it's not in their scope at this time, for one, this bill is saying they're asking for the scope to include that in their scope of practice. And if it's granted, then they're going to have the proper training to do it.
Correct.
And I think I'm hearing them talk about the optometrist and the ophthalmologist, but I haven't heard very much people talk about the actual patient. And I think that both sides, the patient is number one, secondary to money maybe. But of course, the patient is number one.
Agreed.
And I believe that even as a paramedic, over the years, we've had things that we could do that they say would be better for the patients, and we learned it, CEUs do, and the training is there. And a lot of people are not going to do anything that they're not trained to do and hurt the patient. So when you're looking at this scope, if it's granted, I don't see any reason why they can't do it if they're trained to do it. So I'm going to be looking forward to hearing why the ophthalmologist doesn't want somebody who's trained to do something, why they don't want them to do it. So I'm going to be all ears, because if it's about the patient, then if a person's trained to do it, whoever can do it and get to that patient, that's more important than anything. So my ears are open to that. So if you're trained to do it, why not be able to do it?
Right to the point, Representative. I agree.
Okay. All right, Representative, I think that's the last questions we have for you. If you'd like to be free.
I think we've hashed this out. I appreciate the questions from the members of the committee and your time, and I'm looking forward to hearing the rest of the questions in the debate. So I'm going to step out and let you call the rest of your witnesses, Madam Chairman. Thank you very much.
Thank you. Okay, Audrey Valiles, if you will go and.
Mr. Chairman, could Dr. Whitlow go in front of me? He's going to explain the specifics of the bill. I was going to talk about possible amendments and answer the questions that have been raised by the committee.
Okay, surely. Sure, Dr. Whitlow.
Thank you, Madam Chair.
Good afternoon, Madam Chair and members of the Health and Human Service Committee. My name is John Whitlow. I'm an optometrist. I have been in practice with my wife in LaGrange, Georgia for right at 25 years now. Thank you for allowing me this opportunity to speak in favor of House Bill 36. Well, I guess the cat's out of the bag. This is the injection bill, okay? And that's what we've been hearing all around the Capitol since this bill has been dropped. Doctors of optometry that are in school right now are getting the training to be able to perform these procedures. When I was going through school, we were learning about orals and oral medications, and so when I got out of school, Georgia couldn't do orals. So we wanted that scope of practice to expand, okay? But there were those that had gone before me in the practice of optometry that did not learn what I had learned in school. But I think that can be said in every profession. You know, if you've got a medical doctor that is that is working or is in their profession doing the same things in the same ways and the same procedures that they were 20 or 30 years ago, when new things have come out, I would kind of question that. What happens with us is, because we are limited by state law, is that when new things come out, we have to come back and go through this legislative process. So that's one of the reasons we are here today. We keep talking about where this injection's going. It is not going into the globe of the eye, okay? The first layer is called the subconjunctiva on your eye. If you look in the mirror real close, you got a magnified mirror, okay? It almost glistens like a contact, okay? And the way this is written is that yes, that we could go under that first surface, okay? And again, it's like if you had saran wrap on your hand, and that needle goes under the saran wrap but not into the skin, okay? So we are not puncturing the globe of the eye. And a lot of the questions that have been brought up have been about, well, what if you do go into the eye? What if you do? That's not going to be taking place. And I'll have to defer back to Representative, is it Sharper? Patients first, you know. And sometimes I get a little aggravated when we're going through these fights that the patient does get left out of this conversation. I would never do anything to harm a patient, you know. And so let me kind of get back on track here. Going back to House Bill 36 and taking out the different drug categories that we're under right now. There's always new drugs. There's always new things coming out. They're not going to fit into those categories. Again, we treat the eye. We're trained to treat the eye. We want to be able to use whatever is available to treat the eye. So that's another reason for this bill to come along. Again, going back with the new technologies, some of these drugs are now being formulated instead of in drop to be injectable. A couple of reasons on that. One, it will help with compliance. I know quite a few of my elderly patients, it's hard enough to put an eye drop. If you ever tried to use eye drops, it's not easy sometimes to get that eye drop in. And with the elderly, if I know that we could do really just a simple injection, and that would last them a month or 3 months, I don't have to worry about the compliance of that patient. I don't have to worry about what's going on during that time span. So that would be wonderful. The other thing is that by doing the injection, the drug absorption rate, they are proving can be better that way. So again, it's just an improvement on patient care, and again, things have changed. Yes, ma'am.
We are, it's 3 o'clock, we are on some limited time.
Okay. Just in closing, there was I was listening to a lecture by a corneal specialist, which is an ophthalmologist, a couple of weeks ago, and she talked about some of the different procedures that were out there now, and about how she was going to wait and see which procedure was best before she went and learned that procedure. She didn't learn it in school. She was going to go learn it. Now, I don't know how many hours she was going to have to go. I don't know what type of test she was going to have to take. I don't know. But again, all of that really gets hashed out even on the education side of things. Thank you for your time.
Dr. Whitlow, I have a question.
Yes,
I'm
ma'am.
sure that it was just the nervousness of presenting before us that
Yes.
she slipped and said, you know, the road to hell is paved with good intentions, and no optometrist or ophthalmologist would ever do anything to hurt a patient. But when you said that they would never puncture the eye, I don't believe you can give that kind of guarantee to anybody. And
me
you
go-
said that they would
right.
never do that. And
On purpose.
let's make this. Aren't there 3, different little layers in under this and around the eye? The subconjugal or whatever it is, we'll get the, to explain it to us. I can't even pronounce them. I'm like Earl on some of them. And they're actually only the width of a hair difference between them, so that whichever one you're going into, the next one is only a width of a hair difference.
In the
So-
layers of the eye?
the layers that, cover the
Well, no, and
width of a hair. Well, I guess it depends on
and-
which one of y'all are, what. Okay.
you would have to, again, when you start on these, what you're looking at, and I'm looking behind a slit lamp, which is a microscope. It's amazing at the magnification. And anyway, I don't know what to say, because I mean, do accidents happen? I mean, when we're talking about, and I've taken out many corneal foreign bodies that would make me much more nervous than doing one of these injections. And when you're taking out corneal foreign bodies, now that's where you're getting into microns, and I mean, you're talking about the layers of the cornea compared to, I mean, you're talking about to the layers of the globe of the eye. So.
Okay. Do you know how many hours are required for certification? Could you answer that for me on the question I asked about the certification for these outside training courses?
No, ma'am, I have not. And anyway,
Okay.
Aubrey said that he would be able to address that
Okay.
later. But
Who's got a question?
thank you.
Representative Drenner, do you have a
Oh, I'm
question for
sorry.
Dr. Whitlow?
For you, Madam Chair.
Okay.
You know what would be very helpful if we had a visual
Of the eye?
of the eye that
Okay.
we could look at and understand the different parts of the eye as we're trying to.
See that?
Yes.
Did any of the optometrists bring one? I think what about the ophthalmologist? When they give their presentation, I think we'll have a visual for the eye, Bill. Thank you. We will have one. So, okay. Thank you, sir.
Yes, ma'am.
Aubrey, you ready now?
Yes, Madam Chair.
You
Madam
identify
Chair,
who you
members of
are.
the committee, I appreciate the opportunity to be in front of you today. My father put that plaque on my wall, "The road to hell is paved with good intentions." He also put one that said, "A ship in a harbor is safe," but that's not what ships are built for. And the second one's what I want to talk to you about today. I want to primarily address the discussion regarding amendments and concern. If you would look at your bill regarding House Bill 36 on line, 33 to 35, Representative Price asked about that being struck. We did not strike that. Legislative Council struck that. And the reason they struck that is they said there are several cases that show it is unconstitutional to delegate a legislative function to an administrative body such as a board. And we went back and forth, and I'm just telling you what was, and it was Ms. Story, I believe, who did that. And we said we really didn't care one way or the other, but they felt that was a delegation of a legislative function to a board, and that's why they struck that.
Okay, let me ask Betsy. Betsy, don't we have other boards that list things, or do we?
We do, with some criteria. I think this is, she was talking about, there, the whole reason we have to say the controlled substance list and code, because that was the delegation of authority to an agency to determine those drugs. And so I think that because that sort of approaches that type of delegation, that was, I think, out of caution, so.
Okay.
There's some gray area there.
Well, and while we're on there, the last time we did this bill, it gave the Optoms the ability to use hydrocodone.
Yes, ma'am.
If it became a Schedule II. And, the medical board and all have regulations, and I don't believe at this time, even though it's been a couple of years, that the Optom board has made any rules regarding the correct administration of hydrocodone.
I'm not sure about that. I did also draft an
Anybody?
amendment about the injection of hydrocodone to prevent that, if that came up.
Are there any rules? Okay, I don't think there are any rules to date, and yet that is a function of a, well-functioning board to put out there for their optoms or their physicians to put some guidelines about the administration, especially with our opiate problem at this time.
I would
Okay.
agree, Madam Chair, and I drafted an amendment as well that said they could not inject hydrocodone, but one of the problems we're dealing with is I'd heard that they were concerned about that, but I've reached out no less than 5 times and once in writing, asking for their concerns with this bill and asking for amendments. And to date, they have not come forth and met with us, and I've said I'm open to meet with that ahead of time, because the question I've got from the committee members so far, have you met with them? No, I've asked 5 times and sent, I believe, 1 letter. But so we're having to speculate as to what their concerns, but I drafted an amendment to that as well. Regarding the treatment of systemic diseases, I've heard that was one that has come up. If you look at this bill again, on page 3, lines 69 to 70, it says we can't treat systemic diseases. So one of the handouts that I happen to have seen today is they talk about this could include systemic disease such as diabetes and hypertension, not unless we're rewriting this thing which says we can't treat systemic disease. It says it there in black and white. There's also other places that says we can't do surgery, and optometry is well defined. Of course, if you wanted to restate that in there to say in accordance with optometry as defined in 43-9-1, no problem with that. No problem at all, but systemic disease is covered. You brought up the issue of, and I thought that was, to me, one of the best questions about the continuing ed. One of the things that I have said throughout the process to my colleagues is maybe we need to put an hour in there. They rejected my advice of counsel, which is fine, but now I'm here to tell you I think that's a good question. And you could correct that at line 44 and line 47 by simply putting in there a program of blank hours. And I would suggest 15 hours. That's what I would suggest, but I'm not an education person. Even though I have a master's in it, I'm not an educational person. But I would suggest that you do that at line 44 and 47. If that's what you want to do after the word program, you could inject it there. I think that is really a good comment and a good question. I also had an amendment about correcting the Scrivener's error. I think you're going to do that on your own. I had a few more that added things they couldn't do, but again, I don't know exactly what they want. When I looked at their summary here, all but the last line talked about what we've gone through over the years. And it is true, the optometrists have changed their scope of practice for years based upon their education and experience and their training. But so has medicine. I can tell you, years ago, when I started off in the Walter Reed Army Medical Hospital outside of Washington, D.C., the treatment they had for me, the rehab and the drugs, were quite limited. As it's gone through the years, the treatment has been better for me. And in the last year, the drugs have become much better for my legs. And so medicine has changed and grown over the years, just like optometry has grown. That's nothing new. That is nothing new at all. And I want to emphasize that most of the younger practitioners have had these courses. We're requiring everyone. But again, I appreciate the amendments. I'll be happy to answer any questions we have regarding the bills and any amendments.
I think we have one question. Representative Renner.
Aubrey, you
Yes,
know, Earl said that there are 15 states that have this already.
Yes,
What
ma'am.
are their requirements for their injectable training programs?
I've got a list. I'll be happy to hand it out, but I couldn't tell you. I'm not going to lie to this committee, so I just don't know. I don't know what all their requirements are. Some leave it to the board. Some probably have an hourly, unless someone can correct me, and maybe Dr. James, but I couldn't tell you the hours. I came up with that because it looked like we're talking about training in injectables, not talking about learning about the eye and about anything else except the injection part, and which I do agree with Madam Chair. It should require some minimal hour training, and I've suggested 15 hours after talking to them.
Well, I think, Audrey, that the difference is, and having been an instructor of nursing, you have two eyes, and that's all you have. And the eye is made up of different layers and the eyelids and all. And it's a little bit different than giving and teaching somebody to give an injection in the deltoid of the arm or the gluteus muscle of the wrist. You got a lot more space to get it right.
Yes, ma'am.
And then you have when you are trying to get it right with an eye.
Yes,
and
ma'am.
so I think that makes it a little bit different and why there's such concern.
I think
with
it's a
it.
great amendment. I mean, I've argued for it all through the process. I think we do need a minimum hourly in there. Yes, ma'am.
Okay.
Thank you. Any other questions? I'll be happy to
Yes,
answer.
Representative Newton.
Quick follow-up, Madam Chair. Do you know if it's on mannequins or is it on real blinking, twitching people on those courses? And you say you don't know how many hours it is?
Real blinking, twitching people.
Okay, it is on people, but is it a weekend or do we know?
I can't answer that question. What I can tell you is most of them, see, what we're seeing is it's the younger folks that want to do this because they've already been trained. They've already had it, not for a weekend. They had it in their school of optometry. They've already been trained doing that. But what we're requiring to make sure that we catch everybody in a safety net, whether you've had it in school or whether you haven't, you're going to have to take another course. But real blinking, twitching, squirming people.
Okay. Representative Price. And we'll make this the last question
Okay, my question, and I'm sorry I was out of the room, so you may have covered this, but I'm still not clear what injections actually people want to do. I can't imagine for what purpose would an injection be needed that an optometrist feels they need to be able to do.
I think the doctors of optometry can answer that better than what I can, but I think some things don't respond as well to the oral medications and respond better and more efficiently to an injection. And I think that Dr. Ajamian can elaborate on that, but that's my understanding, Representative Price.
That's visually related.
Yes, ma'am. Yes, ma'am.
Okay.
I just really like an example. I still can't imagine.
To the eyelid, which to the eyelid.
Is Dr. Amanian, are you?
Ajamian.
What is it?
Dr. Ajamian.
Ajamian. Okay, Ajamian. Okay. You can read the J.
Representative Price, I did answer your
since-
question while you're outside the room.
Okay,
on
I'm
the
sorry.
other.
Since we have some time, and the doctor has signed up to speak, can we just go ahead and let him, answer the question? Sorry.
Thank you, Madam Chair. I appreciate it.
Okay. If you could answer before you start what you'd like to say, and we are on a time limit.
I'll just answer the question, Madam Chairman.
Okay, but if you have something else, you had signed up.
Thank you to Dr. Price for her question. And bottom line is that I know the stereotype of optometry is that we deal with vision and hang glasses. I've been up here at the Capitol for 37 years now as legislative chair and volunteer. And I'd be at more Roswell City Council meetings, but I'm down here. Bottom line is that we are trained in the treatment of visual disorders and diseases of the eye. To specifically answer the question and how those relate, there's a condition called uveitis that I know some of you are familiar with, and uveitis is a very difficult condition. I've seen 3 cases in the last 2 weeks that, again, getting back to non-compliance, people could have used drops, should have used drops, didn't use their drops. It got out of control. The iris, the colored part of the eye, sticks to the lens. You've got a crisis situation. You do a subconjunctival injection. Uveitis does affect vision. You can have a patient with a chalazion, which is a sty, which is from a common disease called blepharitis, and it can develop to the point where it's painful, large, and actually needs to be incised. This bill does not cover that. This bill covers the small ones that are pressing enough on the eye, again, to affect vision if you want to relate it back to vision. Those are people that could go in and get that cut open or put on oral antibiotics with all of its side effects, which we can use, and sometimes we try. But there are occasions where an intralesional injection of a steroid will help shrink that chalazion or sty or infection very quickly.
Okay, on the first one, you are saying that for that illness, what was the name of the first one again?
Uveitis.
Uveitis. That is the one where you have to hit the right layer that is a breadth, 1 hair's width away from the other layer, not just anywhere.
That's correct. So the conjunctiva, as Dr. Whitlow explained, the thin covering over the white part of the eye, you're going underneath that.
Right.
And yes, it's thin. I totally agree with you, but it's done every day. It's done in surgery. It's done.
But it's done with people who have had years of training with many, many cases of where they've done it with somebody standing over them as a professor
It's
watching
being done
them.
by doctors of optometry around the country at VA hospitals in the 15 states we talked about. As a matter of fact, there was the discussion about how we practice on each other, and this is the course handout. This was a kind of a sample course, use of injections, that I took about 2 months ago, so I could get firsthand. I've been doing this in a referral center setting for years, but and this was a 5-hour course, and we just laid each other down and did it on each other. So not mannequins, not fake eyes, but real eyeballs.
Okay, and on
And
the
we
sec-
did subconjunctival injections, steroids, etc.
on each other. Okay, but not on patient after patient.
Well, these are human beings, so nobody died, everybody did well.
Well, yes, sir, but there's a lot of difference between doing it under a professor's eye over and over again under watching than doing it once or twice on each other. I mean, student nurses give injections to each other before they go and start, but then they have supervised examples with it. On to the chalazion, or chalazion. It's hard to
Chalazion,
say. I'm like Representative Earhart. Some of the ones I can't
You're
even
fine.
pronounce. Like, I understand from the research I had as being chairman of the committee that about over 95% of those correct on their own. That's what the literature shows. And that the ones that rise to the level that they cause problems are the ones that need to be extracted by
Incised and drained.
Incised and drained.
Yeah.
And so really, if you just leave them alone, they take care of themselves. And the other thing, it seemed that you putting a steroid in them was counterproductive and not what was recommended as the best practice.
It's done by ophthalmologists all over the country and optometrists in 15 states when it's needed. It's not a real common procedure, but neither is the use of oral steroids or oral narcotics that we've come to you for over the years and gotten. We just have it in our pocket if we need it. This is not something that people are going to recklessly be doing and injecting just because we can. I have the unique perspective, so I don't take anybody else's time, of actually having gone through optometry school a long time ago and then an ophthalmology residency. And to your question, you're absolutely right. 4 years of general medicine and medical school, after undergraduate, of course. 3 years of residency, not 4, just to be specific. And then some doctors of ophthalmology go on to do fellowships, many do, in cornea, retina, there are specific areas. So I went through a program, residency program at Bascom Palmer in Miami for the 3 years after I graduated from optometry school. And again, the answer to a question, what's the difference, Representative Drenner's question, a lot of the time that residents spend are learning surgery. And so diseases of the eye, conditions of the visual system we share in common, and then surgical procedures, cataract surgery, etc. A lot of these procedures are done with the patient wide awake. So these are injections. Our practice does a lot of cataracts in addition to other things. We don't put people out to do local injections around the eye. They're wide awake, except under maybe a little bit of Versed twilight. So,
and I would say that you going and taking the residency would be sort of an exception. I'm sure there's some optometrists that do it, but it's not the usual.
There are 300 residencies in this country now, again, at VAs, referral practices like mine here in Atlanta. What I've found being a center director of a referral practice is that optometrists are very conservative and they're very smart. They're not going to do anything, as Representative Earhart mentioned, to risk their licensure and thus their livelihood, to risk a malpractice suit, and to risk harm to the patient. I mean, if that was the case, bills would have been rescinded. All the bills that I've worked so hard on over all these years, malpractice suits, board actions, we just don't see the malpractice rates rising. None of that's happened. We have the lowest malpractice rate of
But that
many
would be
medical
left up to your board, and if the board has not even gotten around to making the rules about the use of hydrocodone, who knows that the board
Yeah, I
would
think
move
it's
on
pretty
something.
clear that we can use hydrocodones, and when it moved to Schedule II, we passed a law to allow us to continue
Yes, sir,
to
I
use it.
understand that, but normally, like the medical board and all, there are rules about the correct administration of it. So,
We'll talk to our board.
Fine,
Thank
I mean,
you.
it's been 2 years. Thank you, sir.
Thank you, Chairman.
Okay, that's, okay. Now, okay, there's questions for you, I'm sorry. Representative Hawkins.
I just had a quick question.
Sure.
As a healthcare provider, I always sort of look out around the curve, and I'm sitting here wondering, are there patients that are being denied health care or eye care because you can't do this at this point?
I think denied, Representative Hawkins, is pretty strong. We have many examples, not only in rural areas, but in urban areas where there's a delay of treatment. And again, you include the things that are coming down the pike, either making a patient travel 40, 60, 80 miles to the next big city, or it's not that easy to just call up. I'd challenge anybody to try it. We have as kind of secret shoppers and calling big ophthalmology practices in town and saying, I have a red eye, I have an emergency, and we're told, we'll see you in a week. I'm not saying that's the standard, but there are plenty of practices where it's tough to get in. There's a lot of busy practices in Atlanta, I know for sure. So it's a matter of time and travel and saving trips and saving extra visits, and it's the same argument we've made over all these years related to access to care and being able to be treated if you need to, and if it's something that the doctor of optometry is comfortable with at the point of service.
Okay, Representative Jaspers.
Thank you, Madam Chair.
We need to move on, so just keep it short.
You bet. Just two things. I want to make sure I got it clear. Representative Peake and I were just want to make sure. So you say this we're asking for today, what you're asking for is done by VA hospitals, no adverse reactions, there are 15 states.
You would, if you could have sat in the 5-hour course that I brought the handout on, which anybody's willing to able to look at, I'm happy to share it. it was taught all by doctors of optometry. Most of them are at VAs and associated with optometry schools that are doing this routinely. And I was extremely proud of their expertise, their experience, and their ability to communicate that to us.
And we were
But
just
you're not saying that they do, that optometrists do this. The question he asked was, do optometrists do this in VA hospital? Are they allowed to do what you're asking?
Yes, the answer is yes. That's how they.
All I need is a yes or a no.
Yes.
I mean,
And follow up, just
I
ma'am,
need to
we're
give
just-
the other side a chance to talk, so if you'll keep their answers.
I will.
Just very
Like
quickly,
a
I'd like to know
deposition, yes and no.
from the
Not quite that bad.
associations and such, is there a map? I think it answers back to Representative Sharper and Hawkins' question. I'd love to see a map at some point where ophthalmologists and optometrists are and see those lack of service areas that are out there at some point. And you're a tough man also. We all kind of looked at you when you talked about the injection in eyes.
I'm a tough man.
No, I can't go.
Thank you. I think that's a compliment. This is the map.
Okay.
Absolutely.
So can we do what? Yeah.
There's
pass.
a number of copies here.
Okay. Representative Price, we need to move along. Can you hold your questions till we get to the ophthalmologist, please? Or you need it, is it a burning question? Okay, Representative Price.
What am I going to say? I'm just curious about the malpractice insurance coverage. If someone were to lose their eyesight, if somebody in insurance can tell me what that's worth
Oh, do you have another
in a
one?
payout?
Okay. What'd you say?
Same as an ophthalmologist doing the same thing to an eye, and they have much more chance of doing it than we do because they're doing surgery on the eye day in and day out.
But it looks to me like $1 million is not adequate.
It depends on the case. I mean, you know, Dr. Price, because you're a physician. I mean, it can vary depending on what damages the jury wants to award.
Right, but I'm talking about minimum coverage.
Well, I think our statute requires 1 million, 3 million. That's what most ophthalmologists and optometrists carry. Now, whether you could be sued for 10 million or 20 million for the loss of an eye,
I'm
of
talking about
course.
the legal requirement to what coverage that you
1
have
million,
to have.
3 million in optometry.
Okay, it just says 1 million here in the law.
The way the policies work, I think most people, when they sign up for $1 million, it's a 1-3.
Thank you for your testimony. Thank you very
Thank
much.
you.
Okay, so we, of course, want to hear from both sides, and I think the rest of the people that want to testify are people for the ophthalmologist. So, are they signed up in order? Or, okay, Dr. Kim.
Good afternoon, ladies and gentlemen. Thank you very much for having me. Hey, Dr. Casella, how are you? Good to see you. So, just for disclosure, I want you to know where I'm coming from. I've been in practice for 10 years, practicing comprehensive ophthalmology, and I'm a cornea specialist in Dalton. I've seen thousands of patients and tons of surgery, and I'm very, very busy. So this is not a turf issue. I don't need this to be busy because I'm plenty busy. The key, and everyone here agrees, everyone on both sides, this is a patient safety issue. So when you make your decision, please focus on the safety. I'm happen to be the president of the Georgia Society of Ophthalmology as well this year. And so on behalf of the society, I want to thank all of you and on behalf of our patients and all of my colleagues for the tireless work and effort you do with these very difficult and challenging decisions you have to make day in and day out. And I know it's not easy, but I appreciate you and thank you for what you do. So regarding House Bill 36, obviously we oppose it. It's too far-reaching and it allows optometrists to do injections and procedures. And I'm going to show you a short video that talks about the most innocuous in that bill. And it's not so innocuous. So go ahead and roll, please.
You got it on? What do we have to do?
Oh. You got this queued up.
Okay. Is it gonna work?
Okay, so while we're waiting on the video, let me go ahead and speak. First of all, after we'll watch the video, first of all, there is no such thing as a simple, innocuous procedure. And unfortunately, those who feel like there's innocuous procedures tend to be people who haven't done procedures. And so all of us ophthalmologists, not just ophthalmologists, but general surgeons, oculoplastic surgeons, dermatologists, all of us who work on the face or any parts of the body, we have a very healthy respect for procedures. In fact, I have a feeling, oh, thank you. Yeah, let me go ahead and stop here.
Eyelid injections. So what's this really about? First, we must classify the reasons for an eyelid injection. Eyelid injections are performed to numb and or treat the problem area. But numbing injections have dangerous risks. Injecting a blood vessel can cause uncontrolled blood pressure, rapid heart rate, seizure, or even death. There are many, many types of eyelid problems, and the vast majority require a scalpel. But when would anyone ever need an injection without a scalpel? This is very uncommon. The main reason is for a chalazion. So what is a chalazion? A chalazion is a clogged oil gland inside the eyelid. The lump is made of trapped oil wrapped around scar tissue, as you can see in the diagram above. Steroids can be injected into the eyelid, and the steroid consists of many tiny little crystals which help reduce inflammation. But does a steroid injection get rid of the trapped oil and scar tissue? No. All it does is reduce inflammation in the sides of the lump. The only way to remove the trapped oil is with surgery, as you see here. So why inject steroids if it doesn't cure the problem? Steroid injections into the eyelid can cause whitening of the skin, eyelid deformity, cataracts, glaucoma, infection, a life-threatening drug reaction, and those tiny little steroid crystals can block the blood vessel to the eye and cause blindness. The Georgia Optometric Association would lead you to believe that steroid injections into the eyelid are easy and safe. But do ophthalmologists perform a lot of steroid injections? No, they do not. But why not? The fact is, most chalazions go away with medical treatment and don't need an injection or surgery. But if it doesn't go away, most prefer surgery over a steroid injection. Surgery gets rid of the trapped oil and scar tissue, and there is no cutting on the skin with the surgery. Surgery removes the problem, the trapped oil. A steroid injection shrinks the chalazion but does not remove it. And if it doesn't work, you might need multiple more steroid injections. Why would anyone choose a steroid injection when surgery would remove the problem? Most patients choose removal over a steroid injection because if they're going to have a numbing injection anyway, they would want the oil gone. And although the risk is low, those tiny steroid crystals can cause blindness. Some eyelid cancers can mimic the chalazion, and if misdiagnosed, can cause blindness or death. Optometrists are eye doctors and are an important part of the eye care team, but they have no training or experience injecting real-life patients. They inject a prosthetic arm or each other as optometry students. This does not qualify as adequate training or experience. Ophthalmologists perform hundreds to thousands of eye and eyelid injections on real-life patients in training. Ophthalmologists are medical doctors, eye surgeons, and eyelid injection specialists. Optometrists are not medical doctors, not eye surgeons, and not eyelid injection specialists. Okay, so we'll just leave that up there for everyone's enjoyment. So first of all, there's no... well, it's part of the reality of doing surgery or injections. So first, there's no such thing as an emergency injection, okay, in the eyelid. Because as stated before, most of the time it gets better on its own. In my practice, when patients come in with this problem, I tell them, put this off for 3 months, use hot compresses, and it might go away. And most of the time, they never come back.
So there's no such thing as we need to get this patient stat to get an injection. It doesn't exist, okay? Sure, I can do this procedure and get paid for it, but what's best for the patient? Is it to get paid and do a procedure, or to do what's right and avoid the surgery? Because there is an important saying in surgery: the only way to avoid a complication is just to not do the procedure at all, to not to do the injection at all. Second, complications do occur. And you're gonna hear, oh, well, you know, we haven't had any complications, but the reality is complications do occur in even the best of hands, and highly skilled, highly trained ophthalmologists and dermatologists and plastic surgeons. And why? Because we're dealing with flawed structures. I mean, we look in the mirror, none of us are perfect. And unfortunately, you'll have complications, not because there's error, but because things do happen. Of course, there's also judgment issues and making sure you make wise choices in surgery. That's another whole point. But please look at your packet. We enclosed 5 case reports, just 5. They're case reports that involve injecting a blood vessel with a steroid causing blindness, accidental piercing and penetration of the eye leading to blindness, and a misdiagnosis of eyelid cancer, which was thought to be a benign growth like this. And those patients either had to have the eye removed and the whole socket removed, or death. So when you say, oh, you know, this is not really a big deal, this is straightforward, please, we have to have a healthy respect when we're dealing with taking care of patients. They deserve that type of respect and reverence when we're taking care of them. And like I said before, these people are highly trained with extensive training and experience, and yet even they have this happen to them. Doing a weekend course, a crash course, and doing this type of procedure and injecting one another, that is just not the same level of quality. And I want to ask you, do the patients of Georgia deserve that? Because you want to increase this access of care, which is really not, you'll see, is really not a major issue. Third of all, I want to tell all of my optometry colleagues, I work with 3 optometrists. I love my optometrists like brothers. They are phenomenal optometrists. They don't just do routine eye care, they also treat medical patients too. And we have a very high concentration of medical pathology in our area. They have over 46 years of experience among the 3 of them. Each and every one of them, when I told them about House Bill 36, they said, this bill doesn't make any sense. They told me it's a bad bill. They don't feel that optometrists need to be doing injections. They said this should be referred to ophthalmologists. They have no desire for themselves to do these injections. Even Dr. Casello told me he wasn't really interested in doing these procedures as well when we met in December over dinner. And they told me, you know, we have healthy respect for this type of injections. We're not going to do it because it's dangerous. We know what can happen. And I want you to know that because I have colleagues in our own building and brothers that I love, they are very important to what we do for our patients. But there's 2 basic pathways of taking care of patients. There's patients who need regular eye care and medical care, drops, medications, etc. And then those who do surgery. And to try to mix and match that, it just doesn't really make any sense. There's 2 clear paths. And last but not least, if a patient comes in with this problem and they see an optometrist who, if this bill passes, and they've done some training on dummy arms and each other, how are they going to disclose to the patient full informed consent when you know there are other options such as observation or surgery to incise the lesions? How can they, knowing that they cannot offer those other services, give the patient the proper informed consent? Because every patient needs to be told the risks, benefits, and alternatives to surgery. And all surgeons know this: risks, benefits, and alternatives to surgery. So if you're going to do an injection, you have to be able to give the alternative And how can an optometrist who does not have the ability or skill or training to do an alternative procedure give the patient full disclosure? They cannot. And so what would happen is they would do the procedure, and if, God forbid, something happens, the patient will feel like, well, if they talk to someone else, oh, well, I could have had this other procedure done. I didn't know about this because it wasn't told to me. And so you can see when you go down this rabbit hole, there's a lot of potential issues. Thank you for your attention.
Okay, here again, we have some time. Representative Henson.
Thank you. One of the things you said was interesting to me. Talk about styes, and you talk about blepharitis. Are they related?
Blepharitis is inflammation on the eyelid, and that can cause the oil glands to get stopped up. And of course, if the oil glands get stopped up, just like a pimple on your face, it can get infection. So yes, they're related.
So why do ophthalmologists never ask adults who have blepharitis if they had a problem with styes when in their youth? I've been to many ophthalmologists. I mean, I'm just curious. Wouldn't you want to have a history of somebody's eyes? And I mean, seriously, I had a problem with styes. I had a father who is a physician. I got treated. I had kids in my neighborhood.
Representative Henson,
Parents
can we
wouldn't let me
get,
play
I
with
mean,
them.
you've asked a question.
But
Can we get an
I'm
answer?
just wondering why.
I guess the question is, why didn't you come to me? Because
you live in
because
Boston.
I will tell you this, blepharitis is a prevalent problem. And so I have stacks, photocopies of treatment sheets on what to do, and I'm distributing them out all day long. So I don't know what happened in your experience, but, you know, I'm sorry. I can't speak for what happened to you.
Thank you. Representative Henson? Representative
I
Henson?
don't know. I'm sorry.
Representative Reinders.
Thank you, Madam Chair, and I'll be very brief. I just have one question, so I'm going to reserve my comments till the end. We're always trying to find that balance of doing the right thing because we always put patients first. You mentioned the phrase crash course.
I don't know if I said that, but anyway.
You did.
Okay.
I wrote it down.
Okay.
I promise you did. And so I want to know how many hours of training, if we're looking to make this reasonable, how many hours of training, since they said maybe 15, how many would you consider for it not to be a crash course?
Well, I mean, you look at the total years of training, it's 4 years of optometry school.
Can you give me a number of hours and continuing?
If they want to do surgery, they should do the equivalent number of years for what we do.
So your
End of
answer,
discussion.
would be unless they go through the same 4 years, which is fine. If that's your position, I get it.
8
But
years.
there's okay, 8 years. If there's not that many hours, then as far as you're concerned, anything short of that would be a crash course.
Yes.
Thank you.
Okay. Representative Sharper.
Thank you, Madam Chair. Thank you for the information.
Thank you, sir.
My question is this, and I may have heard it wrong, or I'm not sure, but did someone say that they are teaching this procedure to the optometrists now?
That's what they're saying. I don't.
Okay, in their school, in their training. Okay.
With rubber arms and on each other, though. That's the clarification from what I've heard before.
Okay. All right, well, I don't know exactly, on that end of it. But however they're doing it, even as paramedic or whatever, we had the rubber arms, and then later on we had the, people in class, that we did it on, but it turned out great. But I'm just confused at the point that why are they teaching this if they don't think they're in a position to actually do it and have it in their scope of practice?
I can't speak for why optometrists are trying to expand their scope of doing procedures and trying to do what ophthalmologists do. That's kind of their own agenda. I'm sorry, I don't know.
Okay, just quick follow-up. Now that the kids are not in here, who's gonna benefit far as money? Let's follow the money now. I mean, to be honest.
There you go. Maybe that's what
what
it's all about.
The optometrists want to do this because they can get more on insurance, or the ophthalmologists don't want them to get it.
Surely
so I just want to get straight to the point.
Well, Mr. Representative Sharper, I think you hit the nail on the head, but I don't know. You'd have to ask them directly.
Okay, thank you.
One last thing. I'm going to pass around this syringe, and I'd like you to each look. Don't hurt yourselves, please, okay? Imagine injecting
All
yourself
right.
with this, please.
Oh, children, be good. Okay. Yeah. Okay. That's right. Don't do it. Just take yourself. Okay. Before we disintegrate into just bedlam, sharper. If you don't hush, I'm gonna pop you one with it. I'm probably the one who knows how to use it. Okay, Dr. Harvey, I believe you're up next. Shh, you're funny.
I haven't had enough training to catch it.
Go ahead and pop. Mark, go ahead and pop him with it.
Madam Chair, thank you. Members of the Health Committee, I'm Dr. John Harvey. I know many of you, and I've been down here many times before. I'm a 30-year general and trauma surgeon in this state. I'm the past president of the Medical Association of Georgia. I'm a member of the Georgia Society of the American College of Surgeons, and I speak from that standpoint today. And in my recent latter years, I am now a program director for the Transitional Year Training Program at Gwinnett Medical Center. I'm happy to say I have my residents back here to see how we deal with our laws here today. One of them's going into ophthalmology. And he's asking me if he can go to a 15-hour course and not have to go to the next 3 years. I'm here to speak against this proposition from a global perspective of the American College of Surgeons and from the Medical Association. The American College of Surgeons, through the Flexner Report, which led to the Joint Commission of Accreditation of Hospitals, was interested in high-quality standards and ensuring that people had the education to perform the procedures that they accomplish. The same with the Medical Association of Georgia, for 150 years in this state, has been interested in appropriate education and standards to protect our citizens. We feel from this standpoint that the expansion of the scope of practice does not accomplish that adequate education background for the technical procedures that are proposed by the optometrist. Rather than belabor that point, I know it's late in the afternoon, I will answer questions if the committee has any regarding that background or that statement.
Don't see anybody.
Thank you,
You're
Madam
really
Chair.
good. You did exactly what I said.
Thank you,
Short and
Madam
sweet.
Chair.
Thank you. I give Dr. Harvey a hard time all the time, so that's it. Okay, Dr. Moore, Sid Moore.
Madam Chair, Committee, thank you very much for having us here. I'll try to be brief and short too. I'm Sid Moore. I'm an ophthalmologist from Macon, Georgia. I know a lot of you. I've been doing this for a while as well. I've been in practice for almost 28 years in Macon. You know, one of the issues that's been brought to the committee's attention is the access to care here in Georgia. There was a map that I think was just passed around that showed where the ophthalmologists and the optometrists are in the state. Access, you know, is an important issue, but access is not all about geographic location. When you start considering how long it takes you actually to reach that provider, you have to dig a little bit deeper. And there's a summary of an article in your packet that's recently been done. It was just published this past year. It used an OpenStreets map project, and it looked at actual drive times that it takes to reach healthcare providers, specifically ophthalmologists and optometrists throughout the United States. And throughout the United States, more than 90% of the U.S. population lives within a 30-minute drive of an ophthalmologist. About 90% live within a 15-minute drive of an optometrist. So access as far as time to reach the provider is really not an issue. In fact, in Georgia, the difference in drive time to the nearest optometrist versus the nearest ophthalmologist is less than 30 minutes for 100% of people here in this state. It's less than 15 minutes for 95+% of people here in the state. And if a patient needs an elevated level of care, if they need to be seen by an ophthalmologist rather than an optometrist, 90% of optometrists practice within 20 minutes of an ophthalmologist. So getting to an ophthalmologist is not the issue here. There's another map that we've passed out in our pack. It's another way to look at the availability of care here in Georgia. And this map shows by color-coded counties the number of ophthalmologists that are within 50 miles of the county seat of that county. And the yellow shaded counties have the lowest penetration, but there's still, none of those counties have less than 7 ophthalmologists within a 50-mile drive from the center of their county. And the color coded, you can see, you can look the map yourself, 2.5%, 11 to 20, 5.5. But the take-home point is that at least 91% of Georgia residents have access to at least 31 ophthalmologists within a 50-mile radius. So you can reach, an elevated level of care if you need to. I appreciated comments that were made earlier, right at the opening when the bill was introduced, and I hope the word's true, that you've been given liberty to vote the way you're most comfortable voting based on the merits of this bill. And that's what it sounded like to me. And I think you've heard some about the level of training. You're going to hear just a little bit more in a minute. The best possible care is going to be provided by those with the most extensive training. And if there's not an emergency, and none of these issues that they're asking for with this scope is an emergent issue, then the best possible care that could be delivered to the patient is going to be by the most experienced provider, ophthalmologists who are readily available. So I can answer any questions. I'd be happy to.
Thank you. You have no questions, Dr. Moore. Thank you. Dr. Walsh.
Yes. Thank you, Madam Chair and committee. Thank you for the opportunity to speak. My name is Steve Walsh. I'm an anesthesiologist in Roswell, Georgia. I'm president of the Medical Association of Georgia, which represents physicians in every specialty and practice setting throughout the state. I believe House Bill 36, albeit well-intended, could place thousands of Georgians at risk of blindness and other serious eye health complications. I don't want to repeat what's already been said, but I do want to bring a little bit different perspective to the table. House Bill would allow optometrists to make injections and perform other delicate procedures in and around the patient's eye or eyelid, procedures that they are not qualified to perform. I understand that this is a proposal to increase the scope of their practice. In today's day and age, yes, we do need to leverage our talent to provide patient care. And I do this as an anesthesiologist. I use a nurse anesthetist or physician extenders. But I believe when we look at House Bill 36, this even goes beyond the principles that we put in place for the use of health extenders. The hours of education that the nurse anesthetists that I work with are far less than mine. But I work closely with them as their supervisor and the head of our healthcare team. And what makes this work is they have training in the similar clinical areas that I work in, and I work with them as their supervisor. House Bill 36, this proposal really has no comparison. I understand that optometrists have no patient clinical training in this area, and this proposal would also have them performing procedures independently. So really, it's no training and no supervision, and that's not acceptable. I'm an anesthesiologist, and I perform injections myself where those needle tips come within millimeters of a spinal cord, arteries, veins, lungs, and other organs. But I do not place injections around the eye. I will refer these patients to my ophthalmology colleagues for their expertise. And quite frankly, I believe that optometrists should do the same. So for these reasons, I believe this legislation is a serious threat to patient safety care, and I urge you to oppose House Bill 36. Thank you.
Thank you very much. There are no questions. And last but not least, Dr. Hubbard and Bob Palmer.
Thank you, Madam Chair, members of the Health Committee. It's a privilege to be here before you today and give you some testimony about this bill. I have Mr. Bob Palmer here, who's going to help me with some national perspective on this issue and help me answer any questions that I don't know about the national perspective. Mr. Palmer is the head of state policy for our national organization, the American Academy of Ophthalmology, and very knowledgeable about states' optometric scope expansion in other states besides Georgia, and we'll get back to that in just a minute. I'm an ophthalmologist, and I'm also professor of ophthalmology at Emory University School of Medicine. And in my role as a professor of ophthalmology, I get to teach young doctors how to do many of the procedures that we're going to consider in this bill. And I'd like to just bring some perspective on that and give you some of my experiences. But before we do that, let's just have a little overview of the difference in the training between an optometrist and an ophthalmologist. And keep in mind, now, I work at Emory, so we have optometrists that work at Emory that are my colleagues and my friends. We have a fellow who's actually marrying an optometrist in a few months. You know, we work together all the time. So nothing up here that I'm going to show you is meant to imply that ophthalmology is better than optometry or optometry is better than ophthalmology. There's not a better or worse here. It's just different. So let's just go through this. We'll just cut to the most important part of it. And this is the number of years of training. And I apologize, this is kind of small on the projection, but you see the red oval there, that's circling the number of years of training for optometry, which is 4 years of optometry school, and the number of years of training for ophthalmology, which is 8. That includes 4 years of medical school, 1 year of an internship, and then 3 years of an ophthalmology residency. And then about 40% of ophthalmologists go on to do an extra 1 or 2 years after that, whereas a smaller percentage of optometry trainees go on to do some additional training. So that's the difference in training. And then if you look at the number of hours, I've heard people talk about hours of training. So optometrists spend roughly 1,900 hours in clinical work during their 4 years of training, 1,900 hours. Ophthalmologists spend about 17,000 hours in clinical work during their training. So it's almost a tenfold difference in the number of hours. And that's a big difference. It's a big difference in the number of years, big difference in the number of hours. But even more important than the difference in the number of years or hours is you have to think who's doing the training in these two programs. On the left, you have optometry school, and there the training comes from professors of optometry. Professors of optometry are world experts in optometry. The measurement of eyes, optics, fitting glasses, fitting contact lenses, that's where the word comes from, optometry. It's measuring the eye. Ophthalmology training comes from working with people like me. I've dedicated my career to teaching young doctors how to do these types of procedures around the eye. And it's a totally different thing. If you're in an ophthalmology training program, you're surrounded by people who are surgeons who do these kinds of procedures over and over again, thousands of times in their career. And those are the mentors. Those are the professors that are sitting right there with these trainees, teaching them how to do these things. It's a big difference. Optometrists do a great job at what they do. Ophthalmologists do a great job at what they do, but they're different. They're not the same. So with that background in mind, I'd like to just change gears briefly back to a national overview of what's going on here. And, you know, we've heard some testimony about the risks of injections. We've heard some testimony about access to care, and really there's very good data that we do not have a problem with access to care. We've heard testimony that eyelid injections are not emergencies. There's no condition that you can have in your eyelid that is an emergency. It's not like an EMT that has to do something immediately. These things can wait. If you wait a week to have an eyelid injection, the problem may get better on its own in some cases. So it's not a problem to wait. So what's the real reason? Why are we all here considering this bill? Well, let me give you a little bit of a national perspective. So if you look over the last 20 years at a map of the United States, you can see all of the states in yellow have been subjected to attempts to expand the scope of optometric practice. And you can see almost every state in the country has had some attempt to expand optometric scope of practice. Now keep in mind, training in optometry was 4 years in 1998, and in 2017 it's still 4 years. So there's been no change in education necessarily. This is all done through the legislature, through people like you in all these states. It's a legislative thing, not an educational thing. These are the states that where we saw attempts to have surgery done by optometrists in 2016. These are the states in 2017 where there are scope of practice bills at play in front of the legislature. Again, nothing to do with education here. There's no change in education. This is all being accomplished through legislation. I happen to work closely with North Carolina in my role with our national organization, and optometry has had the authority to do injections in North Carolina for a few years now. And this year in North Carolina, the optometrists are introducing a bill that would allow them to do laser surgery. So I can guarantee y'all have heard testimony that there's been a gradual expansion in the scope of practice. The chairman and sponsor of the bill testified to that. And there has been, and if you look in your packet, there's a list of all of the scope expansions or attempted scope expansions over the last 20 years. I can guarantee you if this injection bill passes, in a year or two, we're gonna all be back here again talking about letting optometrists do laser surgery, just like it's going on in North Carolina right now. So that's a little bit of a national perspective. These are the states where optometric injections have been specifically authorized by the legislature in that state. And if you count them, there are 8 there. We've heard reference to 15. There are some states that are silent on injections. There's some states that allow optometrists to use EpiPens in an emergency. So that may be an explanation for the difference. I would hope that you members of the committee, knowing what you know now about the differences in training, about how optometry is geared towards glasses and contact lenses, diagnosing eye care, and really a very valuable part of the healthcare team when it comes to taking care of eyes, versus ophthalmology that's geared towards procedures and surgery. I would hope that you would keep Georgia among the states that don't have this privilege and not among those outliers that do. I'll leave you with a few quotes. Actually, I have 2 more slides, this one and one other. These are some quotes I'd like for you to read over. These are from materials that have been distributed by optometry to try to raise money to fight their scope of practice battles around the country. Let me just read a few of these quotes. We will legislate our ground floor involvement in all health provider organizations. Next quote. Ophthalmology is so weak politically that we see smooth sailing to the control of eye care. The last quote, we honestly believe that optometry can provide most, if not all, surgical eye care. I'll leave you to draw your own conclusions. I'll also show you a brochure from Oklahoma. This is a brochure that advertises a training course to teach optometrists to perform eyelid surgery. This came out in, this was a course that took place in August of 2016 in a suburb of Tulsa, Oklahoma. It's a 4-hour course from 9 to 1 on a Saturday morning. I personally don't think that's a good idea. I also think that the state of eye care in Georgia right now is excellent. I think all of you here have many more important things to do than worry about whether or not an optometrist can inject an eyelid, and I urge you to vote against the bill. Thank you.
Okay, you have some questions. Representative Mitchell.
Thank you, Madam Chair. Dr. Hubbard, I thought that you'd be the best person to pose this question to, in as much as you have the numbers of the other states that do allow this. Do you have any anecdotal information or any information for that matter that would discourage us from allowing this to happen in this state?
Well, thank you, sir, for that question. I honestly think that Eyelid injections are mostly done to numb the eyes for a subsequent procedure, like excising a lesion or something like that. I don't really think there are very many eyelid injections done to treat things, and I think that's why there are not a lot of examples of malpractice suits on the part of optometrists in these other states. And keep in mind, there are only 8 states where they're specifically allowed to do injections in the eyelid. There are a few other states that are silent on and where they may be doing them, and there are a few states that allow for EpiPens. So I don't think there are a lot of eyelid injections that are actually occurring by optometrists right now. Most optometrists, in my experience, don't have any interest in doing this kind of thing. They would rather, it's a noble profession as is, you know, taking care of people, prescribing glasses, contact lenses, diagnosing problems, treating some problems. It's a great field, and like I say, an integral part of the team.
Representative Beverly.
Thank you, Madam Chair. As you know, I'm an optometrist.
Yes,
and
sir.
I just have a quick question. You said 17,000 hours of training ophthalmologists get. How does that work? Like, how is that physically impossible for the 4 years in ophthalmology? You have an internship. How does it where do you come up with the 17,000 hours?
It's actually 6 years of clinical work. So what you have is you have roughly 60 hours a week, 48 weeks per year, and then it's 3 years of ophthalmology training plus the internship plus 2 clinical years in medical school. So if you do that math, so 60 hours a week, 48 weeks per year for 2 years of medical school, 1 year of internship, 3 years of ophthalmology residency, that's where you come up with the 17,000.
So in that 17,000, so that is sort of a clinical space that you're talking about, all clinical practice.
Yes.
As it relates to this specific bill, how many hours are germane to House Bill 36 that you would say are germane? That's the first question. The second is, when do medical professionals, gone to medical school, medical doctors, actually start dealing with the systems of the eye specifically?
Thank you for that question. I feel like I'm in a good position to answer that question because I participate in training young ophthalmologists on how to do these things. And I'll tell you, I was trying to think of an analogy for what it's like to train someone to do procedures like this. And it's really similar in some ways. It's not a perfect analogy, but it's similar in some ways to training someone how to drive an automobile. So many of you on the committee may have young drivers that you've sat with behind the wheel, where the driver's behind the wheel and you're in the passenger seat and you're in charge of training them to safely drive that car. And you realize that when they're first learning how to drive a car, it's amazing what they don't know. They tend to use too much gas, too much brake. They tend to go too fast or too slow, follow people too closely. They can never park right in the center of a parking spot. They're always off to one side or another, and it can be extremely frustrating. And my experience training people how to do injection procedures around the eye is similar to that. It takes baby steps over a long period of time. It's not something you can learn in a weekend course. You can learn the rules of the road, so to speak, and you can learn the anatomy. You can learn a lot in a weekend course, but you can't develop the expertise to do it safely over and over and over again under many different circumstances like you do in ophthalmology training. It just can't be done, in my opinion.
Right. So but I don't think you actually answered my question. My question was specifically, how many hours would you say? I mean, you said 17,000 hours of training, but when you come to interlesional injections, subconj injections, how many hours would you say? Because I think it's germane to House Bill 36.
Yeah, so I
so
think...
let me finish for just a second.
Sorry.
So my question is, how many hours? Because if there's a number, we sort of like to know what that is. But more specifically, when you start dealing with sort of the systems of the eye, there's a very specific time when medical doctors begin their training for the specificity of eye conditions.
Right.
And all I'm asking is, in that particular scope, for this particular bill, what is the requirement from a training standpoint, hourly, that ophthalmologists are required to do before they are able to do or practice on an interlesional or subconj injection?
I think you're bringing up a very good point. It's very important to have standards, and training programs have to have standards. in order to ensure that the training is uniform and adequate. My point is that it's not something that can be done over a short period of time. It has to be, in order to be fully trained to do procedures like this, you need a little bit at a time over a period of years. So a few hours here, a few hours there, have some reading in between, have the student have time to go home and think about it, watch some other procedures, watch some complications from the procedures, see how the complications can be anticipated, do a few more, go home and read some more, and gradually over a period of years, that's how you learn to do these things safely. Now, we're all worried about patients here. That's the main thing. We want patients to be safe. And you guys here, another analogy to me that's very apropos is aviation. Okay, when we go down to Atlanta Hartsfield Jackson Airport and we get into a jumbo jet airliner, we don't expect that there's a Cessna pilot on the other side of that door. We expect there to be a well-trained pilot who knows how to fly a commercial airliner. And that's what we're talking about here. You can't learn. I'm sorry. You're asking me to put a number of hours on it. Yeah. You can't just.
But you did put a number of hours. So you put a number of hours on it.
Representative Beverly.
Excuse me, but I think it's germane to this bill. So my question to you is specific. Now, the real pushback that I would have is I think that there's a training protocol that you have to have. You have to have a general knowledge of anatomy, physiology, biochemistry, pharmacology, systemic disease. You have to learn that stuff. Nobody's going to go, we're not coming in, I don't know much about the eye or anatomy, and I'm going to actually do an injection. So there's a training protocol, baby steps, if you will, that you have to go through before you're even allowed to touch a patient. And that's just a standard of care issue. So assuming that there is a level of care in optometry school, these baby steps that you take before you're ever even given a 27 gauge needle, what is that in medical school as it relates to intralesional injections and subconj injections, because there's a certain amount of time you have to put in before you can actually do it. And all I'm asking is, I'm not comparing jumbo jets or driving. I'm just saying, what, in your professional opinion, would give you relief to take a medical student or medical doctor, give them the ability to do an intralesional injection? How much time would that require for you to get comfortable, put that, well, this is not the exact needle, but whatever needle it is, the 27 gauge needle, what exactly the time would you say that person should have before they are able to do that?
Well, I see young people like you're talking about, young ophthalmologists that enter our training program. They've finished medical school, they've had some training background in medical school, they've finished an internship, a general surgical or medical internship, and then they're coming to me to learn how to do these procedures on the eye. They're coming to me and my colleagues who work in our Department of Ophthalmology at Emory and a similar Department of Ophthalmology at Medical College of Georgia. So they come to me, and I would say that when they come to us after that 4-year experience, they're very much like beginning drivers, very much like. Do they get better? Yes. Is it something they can learn in a weekend? No. Is it something they can learn from a book? No. They can learn all the anatomy from a book, but they cannot gain the experience of actually figuring out the angle of the needle, how it needs to be injected, figuring out the depth, figuring out the relationship of the tissue between where the surface of the eyelid is and where the cornea is underneath, how hard to inject it. And more importantly than that, figuring out which of these eyelid lesions would actually need some injection and which are likely to get better on their own, and which of these eyelid lesions is actually not a chalazion at all, but rather a form of malignant cancer. So learning all of that, it takes about 3 years, in all honesty, of surgical training.
Okay, thank you. Representative Sharper, we are running out of time, so just keep it to the point.
I'll be real brief.
Thank
Okay, so what we're saying is the optometrists that are getting trained in the other states are able to do this procedure, but they won't be able to do it in the state of Georgia as we speak, correct? All right, okay, and so my point is this. If we have people that need this procedure in Georgia, and it's just only in, let's say you go to the optometrist, but they can't do it,
right?
Then they're going to have to search an ophthalmologist somewhere else in the area, and some of them are rural areas, may not have, know, but.
I'm glad you brought that up. If you would turn to that map that we put in the packet, it shows that 95% of Georgians have not that that's the map that I don't know what's on that
Oh,
map
this the
because it came from the
members,
optometrist. There's
members.
another map. That map, yes,
I
sir.
don't have that
The one
Oh, you got
that
it?
Representative Reinders has. In fact, I can go back to it here in my presentation. So
Somebody get him
the
his.
key
No,
here.
that's the other one. Somebody send him his. It's on the board, but
Yeah, you can't see the fine print here,
yeah,
but
send yours down.
but the
Okay, go ahead.
the data shows that we don't have an access problem here in Georgia. There, for the vast majority of citizens of our state, it is not hard to get in with an ophthalmologist at all, and particularly considering that what we're talking about here is an elective procedure that has no urgency to it whatsoever. And in fact, most eyelid many of these things that they say they would like to inject are chalazions, which actually, if you give them enough time, most of them get better on their own. And if they don't get better, then there's a real concern that maybe it's not a chalazion, but rather a malignant form of cancer.
Okay.
Thank you.
All right.
Representative Bennett.
Thank you, Madam Chair, and I'll be brief. There's a contradiction between the two maps, the one that the optometrist passed out and the ophthalmologist, so I can't figure the difference out. But going back to the states that currently have, where the optometrists currently have injection privileges,
Yes.
has there been a prevalence or alarm or concern to the consumer that there's a problem that exists from malpractice or negligence or all of these horrifying, horrific incidences that could occur that as the picture was painted?
Well, they would all be self-reported, and I will freely admit there have not been a tremendous number of problems that have been reported. However, I will say that even among ophthalmologists, we do see a certain low level of complications from these things. We have all of this elaborate training in place to try to minimize complications, but there's no way to completely eliminate complications. I would argue that if we circumvent this elaborate training that we go through, not to denigrate the optometric training because it's great for what they do, but if you circumvent this very elaborate training that we go through, it's going to just put more patients at risk. And honestly, ma'am, I really think that this is just a stepping stone to optometric surgery. In places where optometrists do have the authority to do surgery, there are a few states where the legislature has granted optometrists the authority to do surgery. If you look at the data from a state like Oklahoma, if you look at laser surgery that's done in Oklahoma, if it's done by an optometrist, it's more than twice as likely to have to be repeated compared to if it's done by an ophthalmologist. So that's good data on a procedure that is done commonly in Oklahoma. I hate for us to see us go there. I really do, because we don't have an access problem here. We really don't. I think our care in Georgia right now is excellent. Like I said before, y'all have much more important things to worry about. And, I like the old saying, if it ain't broke, don't fix it. I think that's where we are.
Representative Jones, last question for
All right,
the
thank you,
doctor.
Madam Chair. My question is about the training. I would like for the author of the legislation or someone to find out what the other states require as a minimum amount of hours. And I would like for you all to consider, or someone to consider, continuing education. Not just for 15 hours of training and that's it. Maybe each year do some training. Because as a cosmetologist or nail technician, we have our continuing education each year, so we have to do that to further what we've learned. So I would like to see some continuing education with this.
Okay. Mr. Palmer, did you have anything to add? No, thank you. Okay, and I thought you were last, Dr. Hubbard, thank you very much, but Dr. Gross has come in, and since Dr. Gross is chairman of our medical board, I'm going to let him do a brief presentation.
I'll be exceedingly brief and past chairman. The medical board's mandate is to protect the citizens of the state of Georgia, and in that regard, we neither represent the ophthalmologists or the optometrists. And at last week's meeting, the medical board did vote unanimously to oppose House Bill 36. Our concerns are purely and simply patient safety, and also I don't want to regurgitate the points that were made by the ophthalmologist and the optometrist, but it all speaks to level of competence and training in performing these procedures.
Questions for Dr. Groves? There's no further questions. Okay. You want, Representative Everhart, you want to, nope, you're.
This committee has had plenty of testimony. I think everybody's capable.
Well, and I want to take this time to say thank you very much to all the committee members for putting up with this long. Okay. Representative Reinders.
Thank you, Madam Chair. And I mentioned I was going to keep my comments brief and towards the end. Me and you have watched this movie for how many decades as it relates to a lot of these kind of scope issues. My dear friend and sweet mate Alan Peake came in here several years ago with the medical marijuana bill and kept talking about having the courage to talk about it. And I said then, but we still have to do it the right way. I've watched this committee today talk about access, and we talk about that all the time. When it came to the dentist, it was they didn't have any. The standard this time seems to be we're within 50 miles. It's a standard that we've got to look at what is access. When you come from the 2nd Congressional District, where 2/3 of the births are Medicaid births, access does matter in that regard. But we changed the standard. Is our standards 50 miles, or is it counties without it? Because not all counties should have whatever it is, because they're frankly just too small. But we've watched this as it relates to Medicaid expansion, hospital provider fees. Just this committee had to talk about, Dr. Kim, where are you at? Please raise your hand. The best line of the day, complications do occur. Complications do occur. And I've seen this committee when we look at dental hygienist versus dentist. Well, those complications don't occur. And we get all over the board according to who's arguing with us and the relationships we almost have. Both sides have come into my office on this, and I'm not trying to lecture whatever. I do think in some places we have an access problem. I do think this map here is different than this map here to a certain degree. I do wonder what is the proper amount of training. We have to make tough decisions like that, but we get scope issues every single day. And what I'm going to ask you, and I ask it every time, I ask it on dentist if I remember right, Madam Chair, are y'all going to come back in 2 years and ask for a laser? Are you going to come back and ask for the change of that scope? That's what you were accused of. Are you going to tell us this is what you want and this is what you need and this does it and this is the access that we need in Georgia? I want a commitment.
I may change my mind between now and then with technology that comes back. I mean,
But you get the point. We do these movies and then they.
It's not a good policy.
Ma'am, we do this and we see the movie come back every day, every year almost, and we have to go through the same thing every year, every other year. Thank you, Madam Chair.
Okay, we are to the point. What is the wishes of the committee? What do I hear? I asked what the committee wants to do.
I make a motion to pass, Madam Chair.
Okay, we have a motion do pass. Do I hear a second? Okay, like that. All right. I have a motion do pass. Any discussion? All right. We normally take a voice vote, and we can do it without people screaming. We'll do a voice vote first. Is there everybody in favor? Say aye.
Aye.
Everybody opposed? No. No. It would seem like the noes have it, and all right. All right. I'll move for a hand count. Everyone, and hold your hands up so we can keep it. Everyone in favor of the passage of the bill, raise your hand.
Raise just one hand, right?
One hand. Okay, everyone opposed?
12.
No, that was the no votes have it, the bill does not pass. So, pardon? 12 nays?
You want to redo it?
If we had, you counted 12 to 12, then the chair votes no. The bill does not pass.
Oh, are we done? Got
That's
another
not what
bill?
we have. Huh? No.